So this is the main arrhythmias you need to know for the PLAB 1 exam. So whenever you come across an arrhythmia, the first thing you're going to do is determine if you're working with a bradycardia or a tachycardia. So let's start off with bradycardias. On the PLAB 1 exams, your bradycardias are basically going to be your AV blocks, atrioventricular blocks. You're going to have three kinds of AV blocks: first, second, and third degree. On your first degree AV block, you're going to have an elongation of your PR interval. And this will be a constant elongation. That means every PR is going to be similarly enlarged as the previous PR interval, okay? Now, with your second degree AV blocks, that's where you drop beats. So that's how you identify them. There's two types of second degree AV blocks, and they both drop beats. So in the first kind, you're going to have a PR that starts lengthening until suddenly you miss a beat. Then on the second type of second degree AV block, which is Mobitz 2, you're going to have a constant PR interval, and then suddenly you lose a beat. Finally, on your third degree AV blocks, you're going to have complete dysregulation between PRs and QRSs. Now, the distance between your QRs is still going to be similar, and the distance between your Ps is still going to be similar, but they're not linked whatsoever. So there's a P here, a Q here, a P here, a Q here, so they are totally dislinked. So for any symptomatic bradycardia that you have, you give atropine. Now, from Mobitz 2 to third degree heart blocks, you need to work with pacemakers. That's important to know for PLAB 1. Now let's talk about our tachycardias. So for tachycardias, what you want to focus your attention on is your QRS. That's the first thing you're going to look at. You're going to have an increased heart rate where the QRS is going to stay narrow or become broad. So this is going to be the first differentiating factor. Now, if that heart going fast is using a broadened QRS, it's going to broaden in two ways: in a regular way or in an irregular way. So when you see a broad regular QRS, you're talking about ventricular tachycardia, okay? And your ventricular tachycardia is going to look like this. So the heart is going to go very, very fast, but you're going to have a very similar shape on your QRS, on your ECG. Okay, so the patient might still be awake, and if they are stable, then you can hemodynamically stable, you can use amiodarone. But if there is no pulse, then you cardiovert. Okay. Now, if your broad QRS is irregular, then you're talking about a ventricular fibrillation. A ventricular fibrillation looks as crazy as you can see here. There is no pattern whatsoever. The heart is going very, very fast. And as you can see, there's no proper contraction at any point. There's no proper QRS anywhere that you can see. That means that there is no pulse. No pulse, you cardiovert. Okay? Now, ventricular fibrillation can dangerously turn into a torsades de pointe, where you can see on your ECG a sinusoid pattern, which is this kind of helix pattern that you can see here. This is also an emergency. You cardiovert when your patient is unstable, and otherwise you use magnesium sulfate. So on the other side of your QRSs, there is the narrow QRSs. So the heart is going fast, the QRS is not changing, so it's still narrow, but it can be regular or irregular again. So if your heart is simply going really, really fast, your QRA stays narrow and it's regular, your heart is just going very, very fast, then you have a supraventricular tachycardia, okay, which looks like this. You have really narrow QRSs and your heart is going really, really, really fast. Okay, so here the first thing you're going to do is you're going to try out vagal maneuvers like a carotid massage or the Valsalva maneuvers. Otherwise, you can try adenosine. So for the, I suppose, the most famously known one, if you have a narrow, irregular QRS, then you're talking about atrial fibrillation. Now, your atrial fibrillation, as you can see here, you're going to have irregular QRSs, right, with an erratic baseline. So there is nothing to be seen here, nothing to be identified. There is no discernible P waves. It's just an erratic baseline. So for atrial fibrillation, you can do rate control with beta blockers and then rhythm control with amiodarone. Remembering always to calculate your CHAS-VAS score and decide if the patient needs DOACs or not. Now, AFib is different from atrial flutter in this baseline. Here you can see that we do have something to identify, which is this sawtooth pattern on the baseline, which is different from this totally erratic, irregular, crazy baseline in atrial fibrillation. So that's the overview of your arrhythmias for PLAB 1. Good luck, and thank you for watching.